Hello, Don here. Welcome to Podiatry Practice Mastery. We're going over the $1 Million Formula. And so we're on to Chapter 8 here. Once again, if you want to download the book, you can go to podiatrypracticemastery.com/book. You can get the download. But I particularly think these little podcast episodes are more beneficial. But you'll have an access to listen to them right on that same book page as well if you want. Okay, so we're going to go over now something I call the treatment roadmap. And this is giving structure and clarity to how we treat patients. One of the things I made early in practice was kind of really thinking isolated about my visits, meaning I treated only with one visit intention at a time. And for example, a patient would come in with plantar fasciitis, and for example, I'd say, okay, try some stretching, try some anti-inflammatories and better shoes. And I said, well, come back if it doesn't get better. Or maybe I would make a follow-up in a couple weeks, but there was really no plan. And sometimes patients got better, many times they didn't, but there was really no clear process. And eventually I realized something really important, that the most successful treatments follow a series of steps, not isolated visits. And frequently I see other doctors, their patients come to see me because there's really no clear-cut plan or process, depending if things get better or especially if they don't get better. They don't know what the plan is for the patient. So I want to explain a little bit about designing a treatment roadmap. Okay, I'm going to give you some of my examples for the treatment outlines, and this tells about actually the entire recovery plan from start to finish. I can usually put this on one piece of paper, which I call my treatment sheet, so they know kind of what we're going to do now and what might be next. And this is key. Within these treatment sheets that I fill out, I kind of put a checkbox on what I'm doing now, and then I circle what will probably be planned for the next visit, and then I also cross out things that I don't think are going to be needed. So, for example, things like surgery, AFO, certain things like that. So just to kind of put people at ease, because many times people have these hidden questions that they don't really ask you. So let's go into like musculoskeletal stuff, so such as Achilles tendinitis, peroneal tendinitis, posterior tibial tendinitis. You might even use this for like metatarsalgia. You could use portions of this for like neuromas and things like that. So visit 1 is what I call the diagnosis and education component. So you're going to do all your imaging, you're going to do your x-ray, you're going to do possibly your ultrasound. Many times I wait for the second visit to the ultrasound, and you're going to try the initial things, which for most musculoskeletal things are if they're able to rest, anti-inflammatories, contrast baths, or icing. The reason I kind of like to do contrast baths is because it's something that few people have heard about, and it kind of has a wow factor for it. Because if they do only what they read online, you're not really giving them much value. So that's the benefit, I think, of a contrast bath. Same thing about doing a over-the-counter versus prescription. Many times doctors say, well, let's just give them Motrin. Well, if they're coming to see you, they want to feel like, let's say, a meloxicam or even a Celebrex might be better off, more so in their head than in the treatment. But if they can get Motrin over the counter, why would they need to come to you? So kind of doing things that are kind of doctor-specific. This is going to be the first visit, and this is kind of setting the stage. And so also in this visit, it's doing gait analysis, once again reviewing their x-rays. And I want to pause and talk a little bit about what I learned from another podiatrist. It's called a running commentary. So as you're watching them walk, as you're looking at their x-rays, as you're doing your physical exam, now I actually document what I'm doing because of my scribe. So my scribe, he needs to know what I'm seeing and what I'm doing, and so this makes me do a running commentary. But patients like this. They like to know, even though you kind of say, well, what you have here is palpable pulses, or I can feel your pulses. What you have here is pain to the plantar medial heel region. This is where plantar fasciitis typically is. It's usually not in the arch region. And so all these things are kind of wowing the patient and setting you up, and they'll say, wow, a doctor has never been this kind of comprehensive. Sometimes I'll use my patient presentations, which are like a couple PowerPoint slides, and but most of the time it's just this treatment sheet. So that's kind of visit 1, and they're going to try a few things for 2 to 3 weeks. And I always say, like, if this gets much better, that'll be the last visit. But I say normally my patients don't get better, and normally they have to do Shockwave. So in the first visit, I'm actually introducing Shockwave. I don't really go into all of the information about it, but I say it's not covered by insurance. Very, very effective, about 82 to 85% effective, and it speeds up the healing by 50%. And so I always say, like, if for some patients they say, well, I've tried everything else, maybe you're the second or third opinion, those ones are going to jump right for the Shockwave. And so if they're ready to do that, you just go into it because if it's the best treatment. Other patients, they maybe are more skeptical or they're more money conscious. So these ones, I tend to try these initial treatments, see them back, and I see how much it's bothering them. And this is something I also learned is that, if a patient's having pain, quite a bit of pain for a long time, they're more motivated than the ones that maybe it got better. Maybe they're not having that much pain. So those ones, it's not even many times worth my time to offer them some of the advanced treatments where I don't even think they're needed. So I'm much more careful now. I really do an assessment of, well, how much is this bothering you? Like, how much does it affect you in your day? So if it's not bothering them that long or that much, maybe they're not really wanting to do that much. Or if they're really money conscious, a lot of times I'm pushing that out as well. I have some patient demographics here. They're very money conscious. And for those ones, I just push it out 6 weeks, 12 weeks until it gets really bad. And then I say, there are other things we can do. They're just not covered by insurance. But we'll start with the things that insurance covers for some of those patients. So that's kind of visit 1. Visit 2 to 6 for most of the MSK things for me. If they're not getting better, do an ultrasound visit 2. And then normally I'm doing the 6 sessions of Shockwave. So 2, 3, 4, 5, 6. Okay. And then many times for my patients, if they have damage in the tissue based on the ultrasound, I'm recommending an amnio injection because that's the best treatment to help heal those tears. And then the third visit is where we scan for orthotics. So that's the third visit. And then the visit 7, which would be after all the shockwaves, would be the 6 weeks evaluation. And I also tell them when I'm doing Shockwave at the last visit, I do a office visit. So that last Shockwave, I want to be aware, I have a last Shockwave handout that I give them. And it kind of says, well, this is what's the plan is next. And this is kind of condoning an office visit. So this is how I get an office visit at the last Shockwave visit because we're actually doing an evaluation and management. Now at the 6-week follow-up, I also tell them we might do another Shockwave treatment, but there's no charge. So I don't tend to charge more than 6 times for Shockwave. So I'll add a bonus one at 6 weeks, and then at 12 weeks after that, so 3 months after that, I might even do a bonus treatment. Those are things I just think it's the right thing to do, and some patients just need a little bit more work. And sometimes I'll verify that with an ultrasound, and sometimes I'll even add on like an amnio injection, or they may have to have something else. Now, one thing I want to say, the last visit, or even in the midst of these visits, during this treatment roadmap, many times patients have other conditions. Like you're treating people for a musculoskeletal issue, but they might also have a nail fungus, or they might have an athlete's foot, or they might have something else. And sometimes patients want to treat those at the same time, and sometimes they want to finish one and then do the others. But I always have kind of this running list in my mind of, well, what else can I help this patient with? And I'm not one that always makes them come back for another visit. If I can fit that in and treat the other other thing, like for example doing a Shockwave and then a nail fungus, I'll do a nail sample, or I might do another office visit along with the Shockwave. So this just makes for a higher level visit. So I think always being aware and addressing these other concerns and saying, hey, does this bother you? It doesn't know. If it doesn't bother them, that's fine. But if it does bother them, maybe they're just waiting for you to tell them about it. So for example, I had a patient recently. He had bilateral Achilles tendonitis with bulbous change and pain. And I went over the treatments, and he got 6 sessions of Shockwave bilaterally, which was good for the practice. And then he also had nail fungus. I'm like, hey, did you ever want to get that treated? So I took a nail sample, and we started him on terbinafine. And it was just like no one ever asked him about it. And like he had just all these foot issues that he never got treated. Okay, so that's the musculoskeletal roadmap. Let's go to the wart roadmap. So with warts, first of all, diagnosis and education, review difference between wart and callus. Many times I'll use my patient presentation for this. And then the treatment sheet, I have a lot of the typical things, like the salicid or the topicals that they might use, like 5-FU or Aldera. But usually I find the most beneficial ones are cantharidin, Swift, or laser. I don't think salicid is very effective. And once in a while, only if there's one wart, I might remove it. So when I go over these options, I say, really, the ones that are going to blister and hurt for 2 or 3 days after are the cantharidin and the laser. And so if they're okay doing that, that's covered by insurance. I'll usually say we can try it for a couple of sessions. It's covered by insurance. But if it's not responding, then I'll transition to Swift. Swift, I say, is 4 treatments. They're once a month. So some patients just say, hey, the best treatment, I want the best treatment. The best is the Swift. Actually, the best I would do is sometimes combination. So I'll do Swift and the cantharidin. Now, when I do that, I don't tend to charge for the Swift and the cantharidin. I just charge for the Swift, and I just kind of throw on the canthrone. Okay, I don't add additional billing to that. And then I see them for Swift once a month, or the cantharidin every 2 to 3 weeks, depending on how quickly they want it to get away, get gone. I tell them, you can come back every 2 weeks if you want, or every 4 weeks. It really depends on how quickly you want this to go away. And then also when I'm doing that, once it looks like it's gone, the last visit, I always say that the wart is microscopic. So even though I can't see it, I'm going to put some sal acid on there so that I can get that last lesion destruction code, that last visit. And then I do a big follow-up. That might even be like a 4-week or a 12-week evaluation just to make sure it's totally gone. And if they look and they can see it's totally gone, I have them cancel it. And this is where I make use of my 10-minute follow-ups. So a lot of times these wart, when they're resolved, do a 10-minute follow-up just to make sure it's really gone. And I say you can cancel that if it's getting better. So this is a way I don't kind of waste with a 20-minute slot for those. And then if they feel like they don't need it, they can just cancel it. And same thing with warts. There's always additional things that they might be concerned with that you can treat. So that's warts. Also for nail fungus, let's do that. So for nail fungus, initial visit. Patients always say, can't you just tell by looking at it? Well, I can't. I can't tell just by looking if it's a fungus, especially if you've had treatment before. Sometimes I can tell, like it looks like it's trauma from like a hallux limitus or rubbing in the shoe. But pretty much always I'm doing a nail sample for these patients just to verify, especially if they're coming in after seeing someone else. The second visit is where I review the results, and then I give them my nail fungus treatment sheet. This really has all the different types of treatments. It has the laser option, the oral option, and also the topical option. I don't think topical is all that effective, and I tell them that. They're really the safest, where there's no side effects whatsoever, is the laser. I don't think it's as effective, but it's the safest. And so some just opt for that, and I said if that doesn't work, after 6 sessions, then we kind of go down and do the next one, which would be the oral. So for that, whatever treatment they choose, I also say we have to treat the shoes, and we have to help the nail to grow faster. So nail to grow faster, they usually get two bottles of Theranail from me, and then they also get they do once a month they do UV light, and once a week they do a shoe spray, and then they're also like cleaning out the bathrooms and other things that are on my treatment sheet. And I always say just all these things are just about, they're $200, and you just pick it up on the way out. A lot of my patients might say, well, can I get it cheaper elsewhere? Well, probably not, and it's just easier to get it right here. So then they'll either get the 6 sessions of the laser, or they'll do the oral and then do an oral follow-up. And then if I'm not seeing improvement with the laser, I'll switch them to oral, and if I'm not seeing benefit from the oral, I might switch them to a different type, like a diflucan or a sporanox, because sometimes I find there's another type of a bug that's in there. And then when I see them back, I can either do like I'll do an evaluation at that 3 months to either modify things and then address other types of concerns that they might have. Okay. So that's kind of how I do. These are the most common combination. I think musculoskeletal, warts, and then nail fungus. Rarely do I do like multiple visits for other types of conditions. Sometimes I'll stage things. So for example, I'll do an IND, and then 3 months I'll have them come back and do a matrixectomy if it's a really bad one. Or sometimes I'll do a nail avulsion, and then I'll say in 3 months you're going to do an Onifix. Or sometimes they like Cariflex, so they'll come in every year or every 3 months in the summertime for a Cariflex with my nail tech. So these are some that are done kind of scheduled, but not as much as these other ones. So early in my practice, when I didn't use these treatment processes, patients, they kind of drifted away. Like if they got better, that was great, and if they didn't come back, and they may have seen someone else. And so I find that giving these structured plans really helps the outcomes. And patients, they really stay engaged, and the recovery becomes predictable. So when I treat these patient processes, I usually say this condition usually involves a series of treatments rather than a single visit. Let me walk you through the plan. And that's where I have my piece of paper called the treatment sheet, and I'll check what we're going to do now, I'll circle what we're going to do next, and then I cross off what I don't think we'll need, just to kind of make them at ease that we're not going to need a surgery or anything else like that. So this matters because patients want clarity. They want to know what the problem is, what the treatment's involved, and how long or how costly the recovery is going to take. And these answer all this. So what I would recommend you doing is kind of identify the 5 most common diagnoses in your practice. And I want to be clear, the most common ones for me that have these multiple steps are Achilles tendonitis, plantar fasciitis, or like musculitis, the nail fungus, and then warts. Those are the 3 main ones. You might have more. You might maybe like neuropathy or something else. And then develop a step-by-step process for each, and then train your staff to kind of know these processes. And then once these are standardized, you become much more predictable and effective. So understanding this is easy, but sometimes it's hard to build the systems, and this can make it a challenge. So once again, I'm going to repeat this. If you're interested, we have the $1 Million Club, which is basically something that I help you implement some of these systems and get you access to all of my treatment sheets and things like that. You can modify them. So if you're interested in that, reach out to me. It's under podiatrpracticemastery.com/coaching, and I would ask you to apply for that, because I don't take just everyone. It's people that are really interested in improving, and they're willing to do the work that it takes. Okay, so now we're going to talk next about the visit value. So we're going to go over the visit value multiplier. So what this means is most podiatrists, they focus on volume and not value. So they believe growth comes from seeing more patients, but the real leverage comes from the visit value. An example, I was talking to a doctor recently, and he said that he sees like 50 patients a day, and he has like 4 medical assistants doing nails for him. Like even on my Friday morning when I do nail care that whole day, or the half of the day, it's crazy. Like I don't have time to think about multiplying the value. Like if anything, I reduce the value. Like I'm not doing my yearly diabetic foot exams. I'm not ordering ABIs. Maybe I was doing diabetic shoes when I was sending them out. But like you're so busy, you can't really increase the value. So you're doing like $100 visits, and you're not able to do anything more profitably. So because you're just seeing so many patients. So let me give you an example. So if let's say you see 22 patients a day. The average visit is like $120, so your annual production is going to be $580,000. If you simply take that value from 120 to like 180, your production is about $870. And then if you can get it up to the $200 mark per visit, that's going to bring you to the $1 million mark. So how do you go from 120 to 200? It's pretty easy. It's $80. But how can you can either do it on like doubling the amount of patients, so going from 22 to like 44, then you might be able to get to the $1 million mark, but that is very wearisome and tiresome, unless that's what the practice you want. Or you can try to increase the amount that patients are paying. And I know some patients or some doctors, they say, I only want to do what insurance covers. Unfortunately, if we only do what insurance covers, we're really restricted, and then you're going to have to be in the volume game. Okay, I just want to repeat that. So if you only do what insurance covers, you're stuck in the volume game. And we've actually opted out of some insurances because it really wasn't worth our time. So some insurances we opted out of, like Medicaid, and that is something that you certainly can do. And I was concerned, probably just like you, of what are the referring doctors going to say? Well, they understand. There are places that will see these patients, and if they don't get better, then they're going to come and just be okay with paying self-pay. Okay, so once I started to understand the importance of designing the treatment, and I understood the math, I started to change my thinking. Instead of saying, how can I see more patients, I began to ask, how can I deliver better treatment plans? And these treatment plans, they have better outcomes, and they're also a better value. So several things increase the visit value. And I've talked about some of these before, but I just want to reiterate. Procedures. Anytime we can offer procedures to patients beyond just the office visit, and there are many different procedures that we can do. We can do nail procedures like matrixectomies, Onifix, Cariflex, avulsions, things like that. Anytime we can do a procedure on the skin, you can do warts, you can do lesion destruction, you can do biopsies, all these types of in-office procedures. Maybe you're going to do an exostectomy, flexor tenotomy, all these things, they increase the value. So keep an eye out for that. Orthotics, which patients will do orthotics? I try to do 2 pairs of orthotics per day. So to get 2, you have to offer it many more times. Okay, we'll get into that a little bit later. Durable medical equipment, like when is it appropriate? You have to have certain structures of, like every Achilles and plantar fasciitis patients of mine is getting a night splint. Every patient with equinus is getting a night splint. Cam boot, every like fracture is getting a cam boot. And you have to just have a kind of a process, and also in-office dispensing, having things to dispense in the office, and then making it a choice to offer that. If you're not offering, just get rid of it. Like don't keep stuff that you don't believe works, and you have to just offer it to patients based on their diagnosis. So, for example, patients with dry callous skin, they're going to get a urea-based cream. Just regular skin issues, they're going to get a regular lotion. Every little procedure in the office with an open wound is going to get a post-op kit. Like all these things, these in-office dispensing, every surgery patient is going to get a shower cover, and you have just these things that are really easy to do. And then office visits. I think this is something that can drive visits. So if you're looking at, like I talked about before, other issues that the patients have, that's going to drive up additional office visits. So you're seeing them for one, and you can do another type of an office visit with an additional treatment, and then developing these treatment programs. These treatment programs and a series of visits is really, really helpful. So when these elements kind of work together, the value of the visit naturally increases. And I would recommend you even use what I have. It's called a daily treatment tracking sheet. If you want to see mine, you can certainly email me, don@podiatrypracticemastery.com. This is where I kind of write down, and this is how I do my podcast, of like what are my MVPs, what are my most valuable patients. So I try to get 2 to 3 of these per day, and this just helps me keep my eye on the prize. I tend to write down everything. If I was you doing it, I would just pick the most profitable things, and maybe even some of the least profitable things, so you can realize how you shouldn't do that. What really helped me, though, is if you're too busy and you can't even write that down, it's probably because you're too busy, and so you should consider a scribe, especially if you're closer to the $1 million mark or you want to get there. A scribe really helps me to see more patients. So I would say calculate your current visit value, and that's pretty easy to do. You take your financials or your number of patients and everything, you put it into ChatGPT, and it can calculate it. It's pretty easy to do. Identify what it is and how you can increase it, and then identify the diagnoses that have the greatest treatment opportunities for you. I've told you mine. And then improve patient education for those conditions. So even small improvements can produce dramatic results. Next, we're going to talk about one thing that every podiatrist loves, and that is orthotics.